Hey everyone, welcome to the 2024 Cervical Spine Research Society annual meeting. As you all know, we've had so many wonderful abstracts that were submitted, some of which were podium presentations, which you will see during the meeting itself. We also had a very diverse set of poster presentations as well. And we wanted to take a moment to highlight some of these posters with the video presentations from the authors themselves. So enjoy the next few research projects as they're presented. Hi, my name is Philip Louie, and I'm an orthopedic spine surgeon out in Seattle, Washington at Virginia Mason Medical Center. I'm here to present our virtual poster looking at subsidence following anterior-only anterior cervical corpectomy infusions for cervical spondylotic myelopathy. This is a systematic review and meta-analysis. So as we all know, graft subsidence has been well established and described in ACDF procedures, but much less has actually been discussed in anterior-only cervical corpectomies for cervical spondylotic myelopathy. So the goal of this systematic review was to address this gap in literature and examine the occurrence and potentially contributing factors for subsidence following these anterior-only corpectomies for spondylotic myelopathy patients. And so we looked at studies that described anterior-only corpectomies performed for the diagnosis of cervical spondylotic myelopathy, looking specifically at subsidence and detailed descriptions of the implant characteristics. We excluded any study that didn't have any separate data for patients that had subsidence of more than 3 millimeters. We also ran a meta-analysis as well. So in terms of results, we saw that titanium interbodies demonstrated about a 10% subsidence rate, whereas non-metal grafts subsided approximately 3% of the time, with an overall subsidence rate of approximately 7%. So in conclusion, expandable metal cages resulted in a lower rate of subsidence, and carbon fiber or expandable titanium implants may actually be protective of subsidence. Thank you.
Hi, my name is Anthony Viola. I'm an orthopedic surgeon in Connecticut. I did my fellowship last year at UConn. We did a cadaveric study looking at the intradiscal pressures above hybrid fusion constructs. This all has to do with adjacent segment degeneration. So we know that increased pressures above and below the disc lead to adjacent segment degeneration, and we do not know exactly what the effect is of a hybrid construct consisting of an arthroplasty with a fusion construct is on these intradiscal pressures. We took 6 frozen cadavers. We used an MTS machine, which allows for frictionless movement, and we replaced the C6-7 disc with an arthroplasty, and we stacked fusion constructs above this, and we measured the pressures above and below. Our results demonstrated that there was no specific increase or significant increase in the pressures above or below the arthroplasty alone in any condition. However, we did see an increased pressure above the construct in flexion once we reached a 3-level construct. And once we reached a 4-level construct, we saw that in lateral bending. In conclusion, there have been many studies out there that demonstrate increased intradiscal pressures after 1-level ACDFs. However, this is the first study to demonstrate a hybrid multi-level construct and a protective effect of the arthroplasty on the disc below, but also on the disc above a hybrid fusion construct.
Hi everyone, my name is Chen. I'm a second-year medical student at the Feinberg School of Medicine, and today I'll be presenting on using natural language processing to automate current procedural terminology coding for cervical spine fusions. Healthcare administration makes up a large portion of America's growing healthcare costs. One of the more expensive parts of this administration in spine surgery is CPT coding. Natural language processing can automate this process. In this study, we trained multiple NLP models to automatically CPT code cervical spine fusions by reading operative reports. We assembled a cohort of 4.4 thousand patients that underwent cervical fusion. We then trained each model. I like to highlight ExoNet and ClinVert. These are transformer models much like ChatGPT. ClinVert specifically has been pre-trained on clinical notes. We selected the best model statistically, and then using Shapley additive explanations, we explored what the best model is paying attention to when it predicts a code for an operative report. On the ROC curve, ClinVert is a statistically significantly better overall classifier than all other models. Looking at an illustrative example of Shapley explanations, we can see that ClinVert is paying attention to the correct lines for classifying CPT code 22614. In conclusion, we found ClinVert to be the best overall classifier of CPT codes, and in the future, we will train an even more generalized model that predicts CPT codes for all spine surgeries rather than cervical fusions alone. Thank you.
Hello, my name is Michael Musacchio. I'm presenting our abstract for 6-year follow-up of a prospective FDA IDE trial evaluating a PEEK on ceramic cervical disc replacement. Cervical TDR is now recognized as an effective treatment for symptomatic disc degeneration associated with radiculopathy and or myelopathy. The purpose of this study was to evaluate the results during 6-year follow-up of this single-level PEEK on ceramic TDR used in the treatment of single-level disc disease. We looked at 150 patients from the outset, 125 have completed 5-year follow-up, and 50 subjects have completed 6-year follow-up, and this remains ongoing. For the main outcomes, the mean NDI preoperatively was 63.3 and reduced significantly to 23.1 at 6-week follow-up and remained below 20 for the 6-year follow-up duration. NDI success, as defined by greater than 15-point improvement baseline, was more than 90% at 3-month follow-up and remained greater than 90% throughout 6-year follow-up. The study found that PEEK on ceramic TDR produced significantly improved clinical and radiographic outcomes, which were sustained over a 6-year follow-up period. Reoperation rates were comparable to other published studies, and these outcomes provide additional endorsement for the utilization of cervical TDR in appropriately selected patients. Thank you for your time.
Hi, I'm Pratyush Shahi from the Hospital for Special Surgery, and I'll be speaking on temporal trends of improvement in patients with cervical radiculopathy after anterior cervical surgery. Right, so we all know that anterior cervical spine surgery leads to a significant improvement in radiculopathy. But if we talk about the evidence regarding the temporal trends and the course of improvement, it is still largely lacking. And that is what we tried to assess in this study. Right, so we included patients undergoing ACDF or CDR, the outcome measures for various PROMs, global rating change, and return to activities. And all these outcome measures were analyzed at various post-operative time points. Right, so 284 patients were included. If you look at the trends for VS neck and VS arm, we found significant improvement up to 6 weeks, followed by a plateau after both ACDF and CDR. For NDI and SF12 PCS, significant improvement was seen up to 3 months, followed by a plateau. In terms of global rating change, more than 80% of patients reported feeling better by 6 weeks. And for return to activities, more than 90% had returned to activities by 2 weeks. So coming to the conclusions, patients can be expected to improve up to 3 months after ACDF and CDR. In terms of improvement in disability and physical function, it can be expected up to 3 months. And for pain, improvement can be expected up to 6 weeks. Most patients can be expected to feel better by 6 weeks, and all this information can be very valuable for patient education. Thank you.
Hi, my name is Zach Backstrom. I'm a 4th-year medical student from Georgetown University. I will be teasing my virtual poster titled Fragility Index of Randomized Controlled Trials Comparing Cervical Total Disc Arthroplasty to Anterior Cervical Discectomy and Fusion. So ACDFs and CTDAs are both widely available treatment options for cervical radiculopathy and myelopathy. Yet the literature comparing the two treatment options is inconsistent. So to assess the reliability of this literature, we used the Fragility Index, which is a metric used to assess the robustness of significant outcome variables in RCTs. To accomplish this, we performed a systematic review of RCTs comparing CTDA versus ACDF and included those studies with at least one statistically significant dichotomous outcome. We then calculated the FI for that outcome by individually shifting one patient from the event group to the non-event group and then recalculating the p-value until it was no longer significant. So low FIs correlate with poor study robustness and high FIs correlate with strong robustness. In our included studies, the mean FI was 4.6, indicating that on average shifting just 5 patients from the event group to the non-event group could actually change that study outcome. And alarmingly, almost 90% of studies had more patients lost to follow-up than their FI. So our findings suggest that these RCTs are fragile and raise major concerns about result bias, which should be considered when interpreting literature and applying it to clinical practice.
Hi, I'm Tan Cho from Sano Hospital. Today I will introduce the V-line, a new metric for evaluating the adequacy of decompression in anterior cervical decompression surgery. According to a study comparing cases of complete and incomplete canal widening after VVSO, there was no significant difference in clinical outcomes. This may be because the existing canal occupying ratio only evaluates the size of the region and overlooks the restoration of cervical lordosis after anterior decompression surgery. Therefore, to evaluate the adequacy of decompression, we devised a new assessment parameter called the V-line. The V-line is drawn by connecting the lowest and highest point on the posterior margin of the vertebral body immediately above and below the decompression site. The V-line is defined as V-line negative when it touches the pathologic region. From the results, the COR-based assessments show significant differences only in the JOA recovery rate. However, based on the V-line, clinical improvement were significantly higher in the V-line positive group with greater radiological improvement. In conclusion, the V-line was designed to assess not only the mass effect of the residual pathological region, but also cervical alignment. Thank you.